Welcome, curious minds, to another deep dive. Today, we're plunging into one of the body's most intricate areas, our chest, specifically the lungs and that intriguing space around them. It's wild how many conditions in this area can have strikingly similar symptoms, like, that persistent chest pain or maybe shortness of breath, but they demand vastly different diagnostic approaches, different treatments. It can be a real medical mystery sometimes. So, our mission today is to untangle these complexities a bit. We want to help you understand their distinct characteristics and maybe appreciate the incredible medical detective work involved in figuring out what's really going on inside the chest. Think of it as a shortcut to being, well, better informed about conditions that often cause confusion and worry.
Absolutely. And to guide us, we've pulled from a compilation of pretty detailed medical excerpts on various chest and lung conditions. These sources are really packed with factual clinical details. Our goal is to extract the most vital knowledge. We want to equip you with a clearer understanding, helping you sort of differentiate between what's urgent, what's serious, and what might just be uncomfortable.
Okay, let's start with a really important but maybe often overlooked area. The pleural space.
Right.
That's that tiny, crucial area between your lungs and the inside of your chest wall, right? Designed to let things slide smoothly.
Exactly. It allows the lungs to move smoothly when you breathe. But when things go wrong here, you basically get two main problems. Either too much fluid or too much air.
Right. Fluid or air. Let's start with the fluid.
Okay, let's begin with pleural effusion. This is essentially when fluid builds up abnormally in that pleural space. And it's important to understand, an effusion isn't really a disease in itself. It's almost always a sign of an underlying issue somewhere else in the body. Think of it like a smoke alarm that tells you there's a problem, but not necessarily what caused the fire. It's that first clue.
Okay, a sign. So how do you start figuring out the cause?
Well, we categorize these effusions mainly into two types, and that tells us a lot. First, you have transudative effusions. These happen because of systemic factors causing a fluid imbalance. Imagine your body's overall fluid balance is off, kind of like a plumbing issue across the whole system. Either too much pressure pushing fluid out of blood vessels or not enough protein pull to keep it in. And the most common cause, by far, like over 90% of cases, is congestive heart failure, CHF.
Wow, 90%. That's huge.
It is. Other causes can include nephrotic syndrome, which affects your kidneys,
Mm.
or cirrhosis, a liver condition. And interestingly, with cirrhosis, the effusion is usually on the right side and can cause pretty severe shortness of breath. Shows how connected things are.
Definitely. So that's transudative. What's the other type?
The second type is an exudative effusion. This happens when there's increased permeability leakiness in the tiny blood vessels in the lung lining. It's usually due to local infection or inflammation. Think pneumonia, tuberculosis, various cancers like lung or breast cancer, lymphoma, or other inflammatory disorders. Because of this leakiness, exudates contain a richer mix of plasma, proteins, white blood cells, red blood cells, almost like a thick inflammatory soup.
Soup. Okay, not pleasant.
Not pleasant, no. And within exudates, you have specific subtypes, like peripneumonic, that's uninfected fluid with bacterial pneumonia. Then there's empyema, which is frankly infected, pus-like fluid, or hemothorax, which is just gross blood, usually after trauma.
So if someone has this kind of fluid buildup, how would they even know? What does it feel like?
Well, it really varies. It can be completely asymptomatic, maybe just found incidentally on an X-ray, or it can cause significant symptoms like dyspnea, shortness of breath, or pleuritic chest pain, that sharp pain when you breathe, sometimes a persistent cough.
And what clues do doctors look for?
On physical exam, the medical detective looks for clues. We might find dullness when tapping on the chest.
Like tapping a drum.
Exactly, like tapping on a full drum indicating fluid. There might also be decreased breath sounds over that area, or sometimes a scratchy pleural friction rub, which sounds a bit like walking on fresh snow. It means inflamed surfaces are rubbing together.
Okay, so you suspect it. How do you confirm it?
Diagnosis usually starts with a chest x-ray.
Yeah.
We look for classic signs, like the blunting of the costophrenic angles, those sharp corners where your diaphragm meets your ribs, or a meniscus sign, where the fluid creates a curved line.
Ah, I see.
And lateral decubitus films, where you lie on your side, are really key. They can detect smaller effusions and help see if the fluid is trapped in pockets, we call those loculated effusions, or if it's freely moving. In really extreme cases, the fluid volume can even cause lung collapse or shift the mediastinum, your heart, and major vessels to the other side.
Wow, that sounds serious.
It can be. But the definitive step, the criterion standard for diagnosis, is thoracentesis. This is where a doctor inserts a fine needle to withdraw a sample of the pleural fluid for analysis.
So you actually test the fluid itself.
Exactly. It has a dual role. It's diagnostic The analysis helps us distinguish transudate from exudate using specific chemical tests, like Light's criteria.
White's criteria.
Yeah, it's a set of rules based on protein and LDH levels
Mm-hmm.
in the fluid compared to the blood. Basically, it tells us if it's more watery, like a transudate, or protein-rich, like an exudate. And the procedure is also therapeutic. Removing fluid can relieve that shortness of breath, though we're careful not to remove too much at once, usually no more than 1.5 liters, to avoid complications.
Right, and sometimes you need more detail.
Yes, for more complex cases, like if we suspect trapped fluid or empyema, advanced imaging like a CT scan or ultrasound is really invaluable. It gives a much clearer picture.
Fascinating. So the fluid itself holds the clues. Once you know what type it is, how do you manage it? Is it always about draining?
Well, the core principle always is to treat the underlying disease because, like we said, the effusion is usually just a symptom.
Makes sense. Treat the cause, not just the effect.
Precisely. Beyond that, therapeutic thoracentesis can alleviate symptoms just by removing the fluid. If it's an empyema, that infected fluid, then chest tube drainage is crucial, often with antibiotics. And for effusions that keep coming back, maybe due to cancer or chronic issues, a procedure called pleurodesis might be done. We introduce a substance, like talc, into the pleural space to cause the lung and chest wall to sort of stick together, preventing more fluid from building up. It's like gluing the layers.
Okay, gluing the layers. Got it. So we've talked about too much fluid disrupting that pleural space. But what happens when, instead of fluid, that space fills with air? That brings us to another urgent condition, pneumothorax. Let's unpack this.
Exactly. A pneumothorax is when air gets into that pleural space, causing the lung to collapse, partly or completely. It happens because the air creates positive pressure, pushing on the lung and stopping it from expanding properly.
And there are different ways this can happen.
Yes, several types. Primary spontaneous pneumothorax, or PSP, occurs without any injury, no obvious reason. It's often due to the rupture of a bleb, like a tiny fragile air blister on the lung surface. It typically affects tall, thin men, usually 20, 40 years old, especially smokers.
Huh. Interesting profile. What else?
Then you have secondary spontaneous pneumothorax, SSP. This happens in people who already have underlying lung disease like COPD or asthma. Their lungs are just more vulnerable. Traumatic pneumothorax results from an injury. It could be iatrogenic, caused by a medical procedure like CPR, or putting in a central line, or from accidents like car crashes.
Okay. And you mentioned one that sounded really serious.
Right. Tension pneumothorax.
Yeah.
This is an absolute medical emergency. Positive air pressure builds up rapidly in the pleural space, acting like a one-way valve, trapping air with every breath. This pressure pushes the trachea, the big blood vessels, even the heart, over to the opposite side. It collapses the lung and critically compresses the heart.
That sounds incredibly dangerous, life-threatening.
Absolutely life-threatening. There's also a rare type, catamenial pneumothorax, linked to menstruation in some women.
So focusing on that tension pneumothorax, what are the immediate signs? How quickly do doctors need to act?
Well, generally with any pneumothorax, the symptoms are often sudden onset shortness of breath and sharp chest pain, usually on one side, worse with breathing. On exam, you'd find hyperresonance when tapping the chest like a hollow drum this time because of the air and decreased breath sounds over that area. Unequal chest expansion too.
But for the tension type?
For tension pneumothorax, the key additional signs are those of severe circulatory distress. Bulging neck veins, increased JVP, dangerously low blood pressure, hypotension, maybe pulsus paradoxus, where the pulse weakens significantly during inhalation. It's a rapidly escalating crisis. Immediate action is crucial.
How do you confirm it's a pneumothorax? Still X-ray?
Diagnosis is primarily with a chest X-ray, yes. An expiratory view, where the patient breathes out, can sometimes make a small one more obvious. We look for that clear line of the collapsed lung edge, decreased lung markings beyond that line, or sometimes a deep sulcus sign on films taken lying down, indicating air pooling at the bottom.
So how do you manage these, from a small one to that life-threatening tension situation?
It really depends on the size and type. For a small primary spontaneous pneumothorax, maybe less than 3 centimeters, observation, perhaps with some oxygen, might be enough. The body can often just reabsorb the air.
Okay, so sometimes it fixes itself.
Sometimes. But for a larger PSP, or if the person is quite symptomatic, needle aspiration, or putting in a small chest tube, is usually needed to actively remove the air. For nearly all secondary spontaneous pneumothoraces, because of the underlying lung disease, a chest tube and hospitalization are the standard, often followed by thoracoscopy to fix any leaks.
And the tension pneumothorax, you said immediate action.
Yes. For tension pneumothorax, the immediate life-saving intervention is urgent needle aspiration or needle decompression. You insert a large needle into the chest to immediately release that trapped air pressure. It's like puncturing a balloon. This is done before an X-ray, often based on clinical signs. Then a chest tube is placed.
Wow, okay. That's fast.
It has to be. For persistent air leaks, or if it keeps happening, VATS video-assisted thoracoscopic surgery might be needed to repair the lung and prevent recurrence.
That's truly amazing how quickly they can intervene. And after someone recovers, what do they need to know?
Yet, patient education is key. Avoid significant pressure changes for at least 2 weeks, sometimes longer. So that means no high altitudes, no flying in unpressurized aircraft, definitely no scuba diving.
Right.
And of course, stopping smoking is crucial, as it's a major risk factor for it happening again.
So we've explored these sometimes life-threatening mysteries of fluid and air around the lungs. But what about those chest pains that are maybe equally alarming to the person feeling them, but perhaps less sinister? That's where the detective work gets even trickier, right? Sorting the urgent from the uncomfortable. What's going on there?
That brings us to conditions like costochondritis and tsetse syndrome. Both involve inflammation of the chest wall cartilages, where the ribs connect to the breastbone.
Ah, so it's the chest wall itself, not the lung or space around it.
Exactly. Costochondritis is an acute inflammation, often with no clear cause, idiopathic, or maybe after a virus or some physical strain, like excessive coughing. The key physical finding here is reproducible point tenderness when a doctor presses on specific spots, usually the third, fourth, fifth rib junctions, and the crucial differentiator. There is no palpable swelling. It's often a diagnosis of exclusion, meaning you rule out the scary stuff first.
So the main takeaway is not all chest pain is a heart attack or a collapsed lung.
Precisely. Sometimes it's just your ribs acting up, and knowing that can save a lot of worry.
And tsetse syndrome. Similar but different.
Similar cause, yeah, but the key difference. Tsetse syndrome involves acute, painful, localized swelling. You can actually see and feel the palpable edema, most often around the second and third ribs. It tends to affect younger adults more.
Swelling is the key difference.
It is. And for both, management is supportive care. Pain relief, maybe NSAIDs, ice or heat, gentle stretching, resting from strenuous activities.
Okay. So we've covered inflammation, trapped air, trapped fluid. What about just a direct hit to the lung, like from trauma?
Right. That brings us to pulmonary contusion. This is basically a bruise on the lung tissue itself. It involves bleeding and swelling within the lung, but without an actual cut or laceration. Typically from significant blunt chest trauma, like you see in high-speed car crashes.
A lung bruise. How do you diagnose that?
On a chest X-ray, you might see these irregular patchy areas that look like ground glass. Though, interestingly, it might not show up right away after the injury. A CT scan gives a much better, clearer picture.
And treatment.
Management is mainly focused on pain control and pulmonary toilet, helping the patient cough and deep breathe to keep the lungs clear. Complications like pneumonia or ARDS, a severe lung injury, can happen. But usually the contusion develops over about 24 hours and then resolves within a week or 10 days.
Okay. Now let's broaden our view a bit. Let's talk about conditions that are often more systemic, affecting the whole body or having widespread effects, starting with high pressure in the lungs themselves.
Right, we're talking about pulmonary hypertension, or PH. This is defined by elevated pressure in the pulmonary arteries, the arteries going from the heart to the lungs. Usually a mean pressure of 20 mmHg or higher, measured during a right heart catheterization.
So high blood pressure, but specifically in the lungs.
Exactly. The underlying issue is typically increased resistance in those lung blood vessels. This forces the right side of the heart to work much, much harder to pump blood through. Over time, this drain causes the right ventricle to thicken and enlarge hypertrophy, and eventually it can lead to right-sided heart failure.
And this can happen on its own or because of other problems.
Both. It can be primary idiopathic pulmonary arterial hypertension. This is often linked to a genetic defect, the BMPR2 gene, and tends to affect middle-aged or younger women more often. Or, more commonly, it's secondary, meaning it results from other conditions like left-sided heart disease, chronic lung diseases like COPD or emphysema, sleep apnea, or even chronic blood clots from previous pulmonary embolisms.
What would someone feel if they had this?
Clinically, patients often experience dyspnea on exertion, getting short of breath with activity. In advanced stages, it can happen even at rest. Also fatigue, lethargy, maybe chest pain. On physical exam, doctors might hear a subtle clue, an accentuated second heart sound, particularly the pulmonary component, P2. And they might see signs of that right-sided heart failure we mentioned, leg swelling, fluid in the abdomen ascites, an enlarged liver.
How do you nail down the diagnosis?
Well, an echocardiogram, an ultrasound of the heart, is the most important non-invasive screening test. It can estimate the pressure. But the definitive diagnosis, the gold standard, requires right heart catheterization. This directly measures the pressures inside the heart and pulmonary arteries. It's crucial for confirming pH and figuring out the specific type and severity.
And treatment depends on the cause.
Highly dependent, yes. It depends on the classification group. For some Group 1 patients, certain medications like calcium channel blockers might work. For Group 2, caused by left heart disease, you treat the heart failure. For Group 3, lung disease, maybe supplemental oxygen. Group 4, from chronic clots, might need long-term anticoagulation or even surgery to remove the old clots. It's very tailored.
Okay. And now let's shift to something you just mentioned as a cause of pH, but is a critical emergency in its own right. Pulmonary embolism, or PE. Here's where it gets really interesting and potentially very serious.
Indeed. A pulmonary embolism is essentially a blockage in the pulmonary arteries. It's almost always caused by a blood clot, a thrombus that has traveled from somewhere else, usually a deep venous thrombosis or DVT, in the legs or pelvis.
So a clot breaks loose from the leg and travels to the lungs.
Exactly. It's crucial to understand that PE and DVT are really two sides of the same coin, venous thromboembolic disease, or VTE, and it's serious. VTE is the third most common cause of cardiovascular death in hospitalized patients. So high on the list of things we worry about.
Third most common. Wow. What increases the risk of getting these clots in the first place?
Most DVTs, about 70%, start in the deep veins of the calf or thigh. We often talk about Virchow's triad when discussing risk factors. It's three main categories that promote clot formation. One is endothelial injury damage to the blood vessel lining, maybe from trauma, surgery, or infection. Two is venous stasis, sluggish blood flow. Think prolonged immobilization after surgery, long flights or car rides, paralysis. And three is hypercoagulability. The blood itself is more prone to clotting. This can be due to genetic factors like factor V Leiden, certain medications like estrogen or birth control pills, cancer, pregnancy, even smoking.
So injury, slow flow, or sticky blood.
Basically, yes. When a clot forms, breaks off, and travels to the lungs, it blocks blood flow. This leads to hypoxemia, low oxygen, and causes the lungs' blood vessels to constrict further. Most PEs are actually multiple small clots, and they often affect the lower lobes of both lungs.
That connection between the leg and the lung is really key. What are the symptoms that should make someone or a doctor suspect a PE? It sounds like it could be tricky.
It absolutely is. The symptoms can be quite vague. The most common are dyspnea, that's shortness of breath, affecting over 70% pleuritic chest pain, and cough. There's a classic triad you might read about: sudden dyspnea, pleuritic pain, and hemoptysis, coughing up blood. But honestly, that classic trio is pretty rare.
Okay, so don't wait for all three.
Definitely not.
Mm-hmm.
In a massive PE, the symptoms are more dramatic: fainting, syncope, severe low blood pressure indicating shock, maybe cyanosis, bluish skin, signs of acute right heart failure. On physical exam, the most common sign is tachypnea, just breathing fast. Also hypoxia and tachycardia, fast heart rate. Doctors will also check the legs for signs of DVT, calf pain, swelling, warmth, maybe a loud P2 heart sound.
So it's a complex puzzle. How do doctors approach the diagnosis? You mentioned scoring system.
Yes, it's a real diagnostic journey, often guided by pretest probability. We use tools like the Wells criteria or the PRC rule. These are scoring systems, checklists really, that help estimate how likely a PE is based on clinical findings and risk factors, things like signs of DVT, heart rate over 100, recent surgery, previous VTE.
Okay, so you get a probability score. Then what?
Based on that probability, we decide the next step. For initial clues, we often get a chest X-ray and an ECG. The CXR is frequently normal in PE, which, paradoxically, if someone is hypoxic and has a normal CXR, that actually increases suspicion for PE.
Interesting. A normal test being suspicious.
Right. Sometimes you see subtle signs like that Westermarck sign, an area of the lung looking too clear because blood flow is cut off, or Hampton's hump, a wedge-shaped shadow suggesting lung tissue death due to lack of blood. The ECG often just shows sinus tachycardia or nonspecific changes. But the classic, though uncommon, S1Q3T3 pattern is more specific, suggesting strain on the right heart.
What about blood tests?
The D-dimer blood test is key, especially for ruling out PE. It measures breakdown products of clots. It's very sensitive if it's negative, 500 ng/ml. In someone with low clinical probability based on those scoring rules, PE is very unlikely. We can often stop the workup there.
So it's good for saying no PE.
Exactly. Yeah, but it's not specific. Lots of things can raise D-dimer levels: infection, inflammation, recent surgery, pregnancy, cancer. So a positive D-dimer doesn't diagnose PE, it just means we need to move to imaging.
Okay, so if the probability is high or the D-dimer is positive, you need a picture. What's the best way?
The first choice diagnostic imaging, the current criterion standard, is CT pulmonary angiography, or CTPA. It's a specialized CT scan using contrast dye. It's highly sensitive and specific, showing the clots as filling defects in the pulmonary arteries. Very accurate.
But not everyone can have CT contrast.
Correct. If CTPA is contraindicated maybe due to severe kidney disease, a serious contrast allergy, or sometimes pregnancy, though it's complex, then a ventilation perfusion, VQ scan, is the alternative. This compares airflow, ventilation, to blood flow perfusion in the lungs.
Right.
A mismatched area is getting air, but no blood flow suggests a PE. It works best if the baseline chest X-ray is normal.
Any other imaging?
Well, a venous duplex ultrasound of the legs isn't usually the first step for diagnosing PE itself, but it can be helpful if other imaging is inconclusive or risky. If we find a DVT and the patient has symptoms suggesting PE, we often treat for PE anyway, since about 70% of PE patients have a detectable DVT.
That makes sense. Find the source. So once PE is confirmed, how do you treat this? It sounds urgent.
It is. The mainstay first-line therapy for most stable patients is anticoagulation blood thinners. It's crucial to understand these don't actively dissolve existing clots. They prevent new clots from forming and stop existing ones from getting bigger, allowing the body's own clot-dissolving system, fibrinolysis, to work over time.
Which blood thinners are used?
We have options. The direct oral anticoagulants, or DOACs, like apixaban, rivaroxaban, are often preferred now over traditional warfarin. They have predictable dosing, fewer drug interactions, and don't require routine blood monitoring like warfarin does. So, much more convenient.
That sounds like a big improvement.
It is, for many patients. Alternatively, we can use injectable anticoagulants like low molecular weight heparin, LMWH, or fondaparinux, sometimes as a bridge until warfarin becomes therapeutic. LMWH is the preferred choice during pregnancy and often in patients with active cancer. And importantly, if clinical suspicion for PE is high, we often start anticoagulation immediately, even before the diagnosis is fully confirmed by imaging. Time is critical.
Right, start treatment first. Are there other options besides anticoagulation?
Yes, an inferior vena cava, IVC, filter, a small metal device placed in the large vein returning blood from the legs, might be used. This is indicated if anticoagulation fails or if it's absolutely contraindicated, like with active uncontrollable bleeding or a recent major stroke, or sometimes in patients with very poor heart function who couldn't tolerate another clot. It basically catches clots traveling up from the legs.
Okay. And what about those really unstable patients? The ones in shock?
For hemodynamically unstable PE patients with severe hypotension or shock, the approach is different. The goal is rapid reperfusion, restoring blood flow quickly. Thrombolysis, using powerful clot-busting drugs like alteplase, is first-line therapy here, assuming there are no major contraindications to bleeding.
So actively dissolving the clot.
Exactly. If thrombolysis is contraindicated, due to recent major surgery, stroke, active bleeding, or if it fails, then embolectomy is considered. This involves physically removing the clot, either via a catheter inserted through the blood vessels or through open-heart surgery.
And how long do people typically stay on anticoagulants?
Generally, at least 3 months if the PE was provoked by a temporary risk factor, like surgery or immobilization, that is resolved. For unprovoked PE, or with ongoing risk factors, the decision for long-term or indefinite anticoagulation involves weighing the risk of recurrence against the risk of bleeding from the medication. It's an individualized decision.
And you mentioned LMWH versus standard heparin earlier. Could you quickly clarify the main differences for our listeners?
Sure. Low molecular weight heparin, LMWH, primarily targets one clotting factor, factor S, and has a very predictable response. So it's usually given as a fixed-dose injection under the skin, subcutaneous, once or twice a day, often without needing lab monitoring. Unfractionated heparin, UFH, inhibits multiple clotting factors, including thrombin and factor S, and has more variable effects between individuals. It's usually given as a continuous IV infusion and requires frequent blood tests, APTT, to adjust the dose. An antidote, protamine sulfate, works better for UFH than LMWH. And LMWH has a lower risk of causing a serious side effect called heparin-induced thrombocytopenia, HIT.
Wow, what an incredible journey through the complexities of the chest, the lungs, the space around them. It really underscores the amazing detective work in medicine. How symptoms that feel so similar can point to wildly different things happening inside.
It truly does.
Yeah.
And while those symptoms can overlap so strikingly, Understanding the nuances in diagnosis, whether it's a specific X-ray finding, a subtle ECG change, a key blood test result, or just careful listening during the physical exam, that's absolutely crucial. It makes all the difference for accurate treatment and ultimately for better patient outcomes. It's a field that demands constant learning, that's for sure.
Absolutely. And as we wrap up this deep dive, it kind of leaves you wondering, doesn't it? What hidden connections might exist between seemingly distinct bodily systems? How might that challenge our understanding of disease beyond just isolated organs? Because as we've seen today, so many of these lung conditions are really signs of systemic issues, right? Like a clot from the leg causing a PE in the lung, or heart failure causing fluid around the lungs. It's a powerful reminder of just how interconnected everything is.
Well said. It's rarely just about one organ in isolation.
Thank you for joining us on the deep dive. We hope this has equipped you with maybe a clearer understanding, and we encourage you to continue your own journey of discovery, staying well informed about the fascinating world around you and, of course, within you.